السلام عليكم. أنا دكتور جهاد. حنتكلم اليوم عن محاضرة renal physiology. This is part 1 of renal physiology. I will do it in 2 parts إن شاء الله. أول شيء learning topics نتكلم general definitions. إيش معناتها الأوزمولاريتي؟ عبارة عن how much solutes or particles are in the water. What does that mean? لو جبت مثلا 1 liter of fluids وحطيت في 1000 milli equivalent of salt, the osmolarity will be 2000 لأن في Na وفي Cl salt. لو الفود عندنا NaCl, when I dissolve it in water it will become NaCl. Each one is alone. Okay, so when that happens, the osmolarity is like doubled because I have each one salt will be dissolved to Na and Cl. In contrast, if I put sugar, for example, the whole component of the sugar will stay in the same shape in the water. It will not be dissolved to multiple salts. So the sugar, which is more complicated, will be counted as 1. NaCl, which is the salt, will be counted as 2 because it has 2 particles, not 1 particle. So hyperosmolar means higher osmolarity than your own blood. It contains more salt than your normal range in the blood, which is around, let's say, from 280 to 310. Hypoosmolar means less than your normal osmolarity in the blood. Okay, we have the kidney, we have the renal cortex, قشرة, and we have the medulla, and we have the pelvis, which collects everything from the medulla and the cortex and excreted to the bladder. Nephron, okay. Just to know, we have a vascular component of the nephron, which is the functional unit of the kidneys. We have the vascular component, we have the afferent artery, efferent, which goes out of the Bowman's capsule, and we have the glomerulus. This is the glomerulus. It's torturing around itself, تلتف حوالين نفسها عشان تسوي more space area عشان النفرون can filter more fluids. Here is the Bowman's capsule. Here is the proximal convoluted tubules. Here is the descending lobe of Henle. This is the ascending lobe of Henle. Here is the distal convoluted tubule. And we have the combined. This is the vascular, which we said afferent artery, efferent artery, glomerulus, and the peritubular capillaries. The tubular component, which is tubules, not arteries or veins, we said the Bowman's capsule, proximal convoluted and distal convoluted tubule, collecting duct, and descending lobe of Henle. We have the combined vascular and tubular, which is here. If you attended the first lecture, we talked about the renin-angiotensin system. We have here the macula densa cells, And here we have uh, the substance, we call it matrix, or I forget the name here, but we have here filled with this substance, which will cause the afferent artery to either contract or relax. Okay, we have, as we said, the juxtamedullary apparatus. We talked about this area that is here exactly to secrete renin and to do the contraction and relaxation of the afferent and efferent arteries, to do more uh, filtration or less filtration. We have two types of nephrons. We have the cortical and juxtamedullary nephron. The cortical nephrons, they account for 85% of the nephron. They have short ascending and descending lobe of Henle, and they are mostly in the cortex of the um, kidney. And oppose وعلى عكس الjuxtamedullary nephron, واللي it goes more into the medulla of the medullary part of the nephron, and it has a long lobe of Henle. Here's short lobe of Henle, which is the cortical, and this one actually, which accounts only for 15% of all nephrons, is the responsible for the concentration of urine. Here is more likely to excretion rather than concentration, and regulation here more about regulation more than the urine concentration itself. So the difference between both of them, this has the cortical one has short lobe of Henle. It lies more on the cortex, and it accounts for 85% of all nephrons. Here, as we said, longer, and it lies deeper in the medulla, and the function is for urine concentration. Here is a difference between the cortical and juxtamedullary nephrons. As we said, it contains short lobe, very heavy. The capillary have not much branched because, as we said, in the cortical, it's not mainly meant for concentration of urine. It's more likely to excretion, uh, rather than the juxtaglomerular, which has the capillary called vasa recta, which is here. As you see, it's much more capillarized than the cortical nephron. Do not participate in concentration, as we said, and has normal blood flow. Okay. Here we have the overview. Once the renal artery gets the blood into the glomerular capillary, here I will show you a picture. Here is the artery. Here is something called basement membrane. So this is the artery, lies above it the basement membrane. This basement membrane is actually charged, so it's like prevents some of the things to filtrate through the capillary. So here is the vessels. The blood will come here. Here will be a hydrostatic pressure, will filter the plasma and lots of things with the plasma, but not RBC and not uh, proteins, because they are big and they have uh, negative charge, and the glomerular basement membrane is also negative, so it will prevent them from getting into this area. And we have here the uh, podocyte. The podocyte actually there is a projection زي الأخطبوط، وفيها حوالينها area to filter more um, the plasma that is being filtered to the Bowman's capsule. uh, and this is the podocyte here are very important in mostly something called nephrotic syndrome and minimal change disease, where these are effaced, so that space here being more and more, and this will allow the proteins to be filtered, and this is will be a problem for the body, and we have to deal with it. Okay, here as we said, we have the glomerular filtration. So what is the function of the kidney? There are four main things that the kidneys do. First one, which we just explained, which is the filtration. Second thing, which is the excretion, the reabsorption before the excretion, the excretion, and the, as we said, filtration, reabsorption, excretion, and secretion. So we will go through them one by one. So filtration, as we said, the from the Bowman's capsule, here's the much more hydrostatic pressure will go in here and will filter the plasma and will go to the Bowman's capsule and then to the proximal convoluted tubule. Here, think about it as the one patient per kg. The kidney is filtering like 2 ml, for example, per kg per minute. So if you are 60 kg, you will be expected to filter around 120 ml per minute. And 25% of all cardiac output will go there. The hydrostatic pressure, now we will explain it. So because here is more the afferent artery which goes to the Bowman's capsule is actually usually wider than the efferent. So here is more contracted, which create more hydrostatic pressure in the glomerular capillary, which allows the filter to happen. So here the capillary hydrostatic pressure is 45 millimercury, and the hydrostatic pressure of Bowman's capsule, which goes against the filtration, is only 10. And we have as well plasma protein oncotic pressure. So we have here protein that drags the fluids back to the capillary, which is 25 millimercury. So 10, which is the hydrostatic of Bowman's capsule, plus 25, which is the proteins in the capillary. The sum of them is 35, and the hydrostatic pressure is 45. So this will goes in favor of filtration, will because the difference is 10 toward the filtration side. So basic, we said the first one is filtration, the second one is reabsorption, and we will go through that now, and then the secretion, and then excretion. Here in the Bowman's capsule, we have the filtration, In the proximal convoluted tubule, we have the reabsorption of most of the things. So glucose, um, let's see one here. Okay, so glucose will be reabsorbed, amino acid will be reabsorbed, lots of water will be reabsorbed here. So this is the first, this is the second function of the kidney. The third one here, we're still in the second one. I will explain something called counter current system. What does counter current means? Means a system which goes parallel to each other. So one goes to this side and the other goes to that side. Same here. The arteries as well is called counter current system. The blood goes in here and this goes up here. They are adjacent to each other, but the flow is different. And we have two type of counter current. We have the counter current exchange, which happens in the arteries, because we don't need energy here. And I will explain everything inshallah in a few minutes. And this is called counter current exchange. And we have the counter current multiplier. Why we call this way? Because it needs ATP. Um, it needs energy to do it. Okay, so here the artery we call it the vasa recta, and this is the juxtamedullary nephron, because it goes into the medulla and has long lobe of Henle. I would like, yes, here is a better picture, and I will explain inshallah everything that happens when you filter the your plasma or urine. So once everything is being filtered, the osmolarity will be 300, which is pretty much as the same as your blood. Um, so once it goes to the proximal convoluted tubule, some of the element will be reabsorbed here, like glucose, amino acids, and sodium chloride, until you reach the descending lobe of Henle. Here, something really important will happen. Here, the descending part is different from ascending part. The descending part of lobe of Henle is only permeable to water, so only water can go out, but the salt here and everything else here is not filtered. It cannot go out of the system, so only water will go out. So when we take water out of the salt, there will be more concentration, so osmolarity will increase, osmolarity will increase, osmolarity will increase until it reach here 1200. And now what will happen? The part here is only permeable to salt rather than the water. So here is only permeable to water. Here is not, the ascending part is not permeable to water. It's only permeable to salt like sodium chloride and potassium. So what will happen here is, by ATP we will kick out the salt, so we will dilute. So if we have like 1 liter of urine or water, and there is, let's say, 500 milli equivalent or of salt, we are taking out the salt out of this water, so it will be diluted again. And because we want to have the salt back in the system, we need this salt, we cannot lose them. And I will tell you what will happen. Of course, this will go to the interstitial and the vasa recta, as we say it, but the vasa recta will be opposite uh, to this direction. So when we go here, the water goes out of the system, will go uh, into the vasa recta, and will cause the artery to supposedly uh, be more um, um, in this area it goes more osmolarity. In that area it's supposed to be less osmolarity. I don't know why. I think here it's supposedly to be different. It starts supposedly from like, yes, 300, and will go more salt now. Yes, salt will go more um, here, because as we said before, the less you go, the more salt will be in the vasa recta system, same like the afferent arteriole. But here it's permeable to both water and salt, and it does not need any ATP like here. Okay, so once it reaches the end of ascending lobe of Henle, as we said, the descending only permeable to water, the ascending is only permeable to the salt. So when it actually reaches here, it's actually less osmolarity than your own blood. So it's diluted here. And what will happen to the in the distal part of convoluted tubule, the toxic material like creatinine, ammonia, uh, H plus, which is the hydrogen ion, will be excreted here and will cause uh, the the osmolarity to go up again to like normal osmolarity 300. Okay, so once you go to the collecting duct here, it's start around the 300 as we said, but it's more, as we said, we take out the salt, we give it more toxic material to have the same osmolarity here. We take the NaCl and um, potassium, and we give it ammonia, uric acid, hydrogen, more of these things. So once it reaches the collective collecting duct, it starts with 300. But here in the collecting duct, there's something called aqua boring channels. These channels are actually dependent on something called ADH, antidiuretic hormone, that is secreted by your pituitary gland. So this will be activated if you are, for example, fasting, Saim, and you are dehydrated. This will increase in your body and will cause, will formate more water channels, and this will drag more of the water out of the system, but the salt and waste will stay there, and this will increase the osmolarity of the urine again, but with more toxic material, not the material that you once you started you gave much more of NaCl, chloride, potassium, and now it's much of creatinine, uric acid, and ammonia. Here is a summary of what we said actually. Yes, same. If you understand everything we said, The blood goes to the Bowman's capsule. Here, the ascending, uh, here the descending lobe of Henle, water will go out. Uh, Here, salt will go out. Here, no salt can go out. So the osmolarity will increase here, and here the osmolarity will go back because we are kicking out elements. And once we are here, urea and ammonia will gather, and here the collecting duct is where the ADH works. And if we want more water, we can do more aquaporin channels to drag more water into the system again and not lose it. And if you are well hydrated, and this will decrease the ADH, will decrease these channels, and you will lose more water. Everything that is written here is we already discussed. I will not make this much larger. I will stop here, and I will continue with part 2 in a little bit. Thank you for